Assalamu alaikum everyone. Today we are going to talk about a very important topic, that is acute coronary syndrome. These are the clinical manifestations of atherosclerotic plaque rupture and coronary artery occlusion. Both of these causes decreased oxygen supply to the myocardium, which causes either reversible or irreversible injury to the myocardium. This acute coronary syndrome comprises of unstable angina, non-ST elevation MI, and ST elevation myocardial infarction. All these components are the part of ACS because their initial presentation and early management is almost similar. Now talk about the unstable angina. Let's talk about its pathogenesis first. Suppose this is the lumen of the coronary artery and here is the unstable plaque. As we know that the unstable plaque is more vulnerable to rupture and more vulnerable to ulceration. Due to ulceration, it becomes thrombogenic, that easily platelets deposition occurs on this unstable plaque or the dynamic plaque. So due to thrombus formation, there is a partial occlusion of the coronary artery and causes this subendocardial myocardial ischemia. It is basically a reversible injury. Now come to the non-STEMI, that is non-ST elevation MI pathology. In this case, the pathogenesis is almost similar, that superadded thrombus over the unstable plaque. But here in this case, there is a irreversible injury or necrosis of subendocardial myocardium occurs because of this partial occlusion. And in the ST elevation MI, there is a total occlusion of the coronary artery. On the plaque, there is a thrombus formation. This thrombus causes the total occlusion of the complete occlusion of the coronary artery. So ultimately reduced blood supply and reduced oxygen supply to the myocardium and causes irreversible or transmural injury, that is whole layer of the myocardium is dead in case of no in case of ST elevation myocardial infarction, that is transmural infarction of the myocardium in this case because of the total occlusion of the coronary artery. The time duration of the clinical features in unstable angina is less than 30 minutes and same for non-STEMI, but in the ST elevation MI it is more than 30 minutes. As we have discussed that subendocardial myocardial ischemia occurs in the unstable angina, and subendocardial myocardial infarction or necrosis, that is irreversible injury of subendocardial myocardium, occurs in non-STEMI. And in the STEMI there is transmural myocardial infarction or the necrosis, or the myocytes becomes dead. This is irreversible injury. Now come to the important point. These are the cardiac enzymes which are used to differentiate between the angina and the myocardial infarction, because from the dead myocytes the cardiac enzymes are released, which are troponin and CK, that is creatine kinase MB. These enzymes are elevated in non-STEMI in the myocardial infarction because these are released from the dead myocytes. So these cardiac enzymes are elevated in non-STEMI and the STEMI, while these cardiac enzymes are in the normal range in case of unstable angina. Now come to the ECG changes. As we have discussed in the previous lectures, that subendocardial myocardial ischemia causes ST segment depression, or may be associated with T wave inversion. And same in case of non-STEMI, that is ST depression, because the subendocardial myocardial ischemia or infarction causes ST segment depression. So segment depression plus minus T wave inversion in case of non-STEMI and unstable angina, while there is ST segment elevation in case of STEMI or transmural infarction. There is ST segment elevation. Basically, in the unstable angina, it is new onset of angina or rapidly or newly developed worsening angina with more frequency and more duration and more severity as compared to the stable angina. And this angina is not relieved by the nitrates and it is occurring even at the resting state. In the STEMI, the ECG shows either the ST segment elevation is more than 1 millimeter in two limb leads, and ST segment elevation of more than 2 millimeter, that is two small boxes in two chest leads, and it may be shows that newly developed left bundle branch block. Now come to the clinical features of acute coronary syndromes. that there is a chest pain. It is the most important and cardinal feature. Chest pain is the most important feature. It is basically the substernal pressure sensation, like elephant sitting on the chest of the patient, and heaviness, squeezing or tightening chest pain. And it is more severe and lasts longer than the angina, that is more than 30 minutes in case of myocardial infarction. And this pain or the substernal pressure radiates to the left arm, jaw or neck, and epigastrium because of the same dermatome. Patient may develop anxiety or fear of being dead. Because of the myocardial infarction or dead myocyte, the myocardium becomes immotile, and the features of cardiac failure occurs in some patients. These includes the raised JVP, that is elevated jugular venous pressure, and dyspnea because of the left ventricular failure causes pulmonary congestion, and crackling sounds can be heard by the stethoscope in the lungs basis, and S3 gallop, that is ventricular gallop because of ventricular overfilling, and atria when contracts against the stiffened dead ventricle, so S4 is also produced. Because of the cardiac failure, there is a reduced cardiac output and reduced blood supply to the various parts of the body. So as a compensation, there is sympathetic overflow or sympathetic over discharge, which causes the tachycardia or increased heart rate, and palpitations can be felt by the patient. Cold peripheries because of sympathetic over discharge, or maybe due to reduced cardiac output or reduced supply to the peripheries, and diaphoresis because of sympathetic over discharge, and pallor. So these are the features because of sympathetic over discharge. Also, there is autonomic nervous system upset causes the nausea and vomiting. Sometimes the patient may develop the sudden cardiac death. If it occurs within first hour, it may be due to ventricular fibrillation or ventricular tachycardia. But after few hours, if the death occurs, it may be due to congestive cardiac failure or simply heart failure. Sometimes the patient develops the silent myocardial infarction. It occurs in the patients of diabetes mellitus because of neuropathy. Patient cannot feel the pain, and elderly, and in some women. And also that if the patient has transplanted heart which is denervated, so all in all these cases the patient may develop, in just 10 to 20% of the cases, the patient may develop the silent myocardial infarction, that is painless myocardial infarction. Now come to the investigations of acute coronary syndrome. ECG is the best initial investigation to check the acute coronary syndrome. The early feature is peaked T waves or tall T waves. These are basically usually missed by the doctors because these occurs in very few seconds and few minutes, and then these are usually missed by the doctors because they disappear after few minutes. The most important and the earliest feature is ST segment deviation, which may be ST segment elevation or which may be ST segment depression. In transmural injury, the ST segment elevation in the STEMI case, the ST elevation occur, and in the non-STEMI and the unstable angina, the ST segment depression occurs. And also there is T wave inversion, and then which shows the basically ischemia, not infarction. And in the Q waves, which shows the prior myocardial infarction or the previous MI. The other important investigations, we have discussed all the features of ECG in the section of the ECG lectures in detail. Now come to the next investigation, that is cardiac enzymes. These cardiac enzymes are troponins and CKMB, that is creatinine kinase MB. These two enzymes are very important to differentiate between the angina and the myocardial infarction, because these enzymes are elevated in non-STEMI and the STEMI, while these enzymes are normal in range in case of unstable angina. These troponins are much more sensitive and specific, so these are gold standard as compared to CKMB. Usually, these two enzymes are raised in 4 to 6 hours in the blood, and CKMB is usually highest or peak at the 24 hours, and after 3 to 4 days the CKMB levels becomes normal. So this CKMB is very important to check the reinfarction after admitting the patient. And these troponin levels are initially started to be raised in 4 to 6 hours and then elevated at the peak levels in 24 to 48 hours, and they remains in the blood elevated up to 14 days, that is 2 weeks they remains elevated. So these are much more sensitive and specific for checking the acute coronary syndrome, simply the myocardial infarction. The next investigation is chest x-ray, which sometimes shows the cardiomegaly and pulmonary edema, because the patient develops the pulmonary edema because of the cardiac failure sometimes develop in the patients of myocardial infarction. And echocardiogram or the ultrasound of the heart is very important before discharging the patient from the hospital, to check the complications of myocardial infarction like mitral regurgitation, like myocardium rupture or the pericardial effusion, and all other complications or the motility problems of the heart can be checked by this echocardiogram. So this is very important before discharging the patient. So this was whole about the acute coronary syndrome and its investigations. We will discuss the management of acute coronary syndrome in the next video. Thank you so much for watching this video.